Good afternoon, everyone, and welcome to our second webinar in our series that's made possible by a grant from the American College of Neuropsychopharmacology. I'm Nancy Shimon, the Program Manager for CABF, and I'll be moderating today's webinar. Joining me on staff are Shira Rader and Jessica Jimeno, who will be assisting me with any technical issues you might have related to the webinar, and also triaging our questions for our guest today, Dr. Daniel Pine. Before we get started, I just would like to go over a few quick housekeeping tips to help everybody have the best experience possible with this technology. First of all, you can listen to the webinar through either your computer speakers or a headset or by telephone. So refer to your webinar invitation for the telephone directions and phone number. And if you do have any problems or questions, just type that into the question box and we'll respond privately to you as quickly as possible. We are going to be recording this webinar, and it will be available on our website in the chat and webinar section. If you click on the Connect tab on our website, this should be available within the next few days, so you don't have to worry about taking notes, or if you miss anything, you'll be able to hear and view the program in its entirety. All of our attendees are going to be muted during the program. This is to prevent any background noise or microphone feedback that would come through while Dr. Pine is presenting. We will have time during the program for questions, so please feel free, as some of you already have, but go ahead and start submitting your questions in the question panel, and we'll be reviewing those, and we'll either interject those during the presentation or holding them until the end. And Dr. Pine has promised to give us ample time for questions, because I know that that's one of the most important and beneficial parts for our attendees. So we will try to get to as many of those as possible. Understand we can't answer everything. We can't address any specific case studies or case situations relating to your specific child, but we will try to address things in a more general nature that it would be appropriate for more of our attendees. And again, if you have any technical problems, please let us know through the question box, and we'll get back to you as quickly as we can. So now I think we're ready to start today's program on anxiety and depression in children and adolescents. As I mentioned, our guest today is Dr. Daniel Pine. He's a member of the American College of Neuropsychopharmacology, who very generously provided the grant for these webinars. And he is the chief of two divisions within the National Institute of Mental Health. These are the section on development and affective neuroscience and the emotion and development branch in the mood and anxiety disorders program of the NIMH's intramural research program. It's a lot of titles and words, but hopefully you can get a sense of just how qualified Dr. Pine is to talk about the issues that concern so many of us. He's been engaged continuously in research focusing on the epidemiology, biology, and treatment of psychiatric disorders in children and adolescents. His areas of expertise include biological and pharmacological aspects of mood, anxiety, and behavioral disorders in children, and is reflected in a series of more than 200 papers on this topic. So I am very thrilled to introduce Dr. Daniel Pine, and I will now turn the microphone and screen over to you, Dr. Pine.
Wonderful. Thanks a lot for that kind introduction, and I wanted to thank all the audience members. I think I see we have 127 people listening, which is just terrific. So I'm going to try to make very economical use of the time. I'm going to try to speak for a half an hour, and you have my slides, and I'll tell you, I'll walk you through those in a second. And then what I'm going to do is I'm going to open it up for the final 25 minutes, really to take any questions that we have time for. And I'll be very interested in hearing from parents and families, either with questions about the material that I'm going to cover in the next 25 minutes, or about really any other issue that we brush on or even that we don't mention. And when you think about the material that I'm going to review, you can really think about it in kind of two areas. So the first thing that I'm going to do is I'm going to talk about clinical advances, and I'm going to take most of the time talking about these issues. So I'm going to talk about what we know from longitudinal studies, what happens to children and adolescents with depression when we follow them over time, from family studies, how problems in children and their parents segregate within families, and from treatment studies. And I'm going to spend really as much time as I can talking about treatment. And then I'm going to end really in the last 10 minutes or so by talking about what we've learned about the brain, and most importantly, how that's going to help us think about doing better things for kids who are having problems with anxiety and depression. I'm really going to be talking about two broad sets of problems. The first one is something called major depression. So major depression is extremely common. Somewhere between 5 and 20% of children and adolescents, if we follow them from really preschool aged into their early 20s, about 1 in 5 will develop suggestive signs of major depression. Now, when we talk about major depression, we need to be very careful to differentiate major depression from normal varieties of depression. So when we talk about major depression, there are two important things to note. The first thing is that when a child suffers from major depression, they have to have depression that is present every single day for many days in a row. And this is very different from other problems where we might see depressive symptoms, but we would not give that child a diagnosis of major depression. The second thing to say is we think of depression as being abnormal when beyond this persistent level of depression, it impacts on a child's ability to function, or what we call impairs the child. And we think about impairment as manifesting in missed school or problems with friends or problems in family life. So we really need to see those two things. The depression has to be persistent and prolonged, and it has to interfere before we think of it as part of a major depression diagnosis. There's a very strong relationship between age and gender. Depression tends to be relatively rare before puberty and about equally as common in prepubertal boys and girls. After puberty, there's a much stronger association with girls than there is in boys. And we know that this has something to do with hormones, but there's a very complicated relationship between hormones and depression and gender that has to do with the complexity of the relationships between stress, hormones, and the brain. The big thing to know about major depression is that once it starts, it's frequently recurrent. So in a minute, we'll be talking about anxiety, which is very different from depression, both in terms of how it presents, but also, most importantly, this tendency to become recurrent. So the hope is if we can better treat anxiety in children before it really becomes chronic, we might be able to both help anxiety, but we might also be able to help depression because anxiety has a very strong relationship with depression. One of the things I'm not going to talk about is I'm not going to talk at all about bipolar disorder in the comments that I make. I know that there will be other webinars where there will be very in-depth discussions of bipolar disorder, and I know that people might have questions about bipolar disorder, which I'd be happy to answer, but the main focus of the talk today is really about major depression, number one, and then anxiety disorders, number two. Well, so what do we know about anxiety? So when I was talking about depression, I was really talking about one type of problem, major depression. When we talk about anxiety, we tend to split anxiety problems into three groups. One group we call obsessive-compulsive disorder and related syndromes, or OCD. A second group we call PTSD, or post-traumatic stress disorder, or stress-related syndromes. And then a third group has a mixed variety of anxiety disorders, things like phobias, panic attacks, generalized anxiety disorder, or GAD, and separation anxiety disorder. In some ways, these three groups of anxiety are unique. Kids who have one kind of problem are somewhat different than kids who have another problem, but in other ways, the disorders are quite similar, in particular when we start thinking about treatment. So anxiety is even more common than major depression. About a third of children will have a significant anxiety disorder in some point during their development before they reach their 20s. And the same question about what's normal and what's abnormal in anxiety comes up as we talked about in depression. And again, this idea of impairment, that we think that anxiety is abnormal when it's interfering with the child's ability to do things. Now, it can be more tricky to separate normal from abnormal anxiety than it is from normal as opposed to abnormal depression, and that's because one of the other things that we rely on in anxiety is, do we consider the amount of distress that a child has to be extreme? And this is a judgment call. It involves the expert opinion of a doctor, and there's some wiggle room for interpreting when distress is really extreme as opposed to when it might just be a little elevated. So we feel most comfortable in diagnosing an anxiety disorder if it interferes with function or has impairment. Now, for both of these areas, I will, at the end of my comments, I'll talk about the brain. The hope is that one day we're going to be able to use what we're learning in neuroscience to better understand this distinction between normal and abnormal anxiety or normal and abnormal depression. Unfortunately, we're a long way away from doing that, however. Now, there's also a relationship between age and gender and anxiety, and that relationship is different than when we see in depression. As I mentioned before, there is a strong relationship between anxiety and depression, but again, this relationship with age, where we talked about in depression as relating to a high rate in adolescent girls, is different in anxiety. So anxiety is very common in childhood. It doesn't necessarily show this increase with puberty, and we see high rates of anxiety in girls in very young age children. Children on their entry into the school age years are more at risk for anxiety when they're girls as opposed to boys. As I mentioned, there's a very strong relationship between anxiety and depression, and we're going to be talking about longitudinal outcome data in just 1 second. All right, well, so there are many different studies that have been done on longitudinal outcomes, and I'm just going to walk you through one slide here from a study that I've been involved in for about the last 20 years. And what this slide shows you, you can see in my pointer, there were about 700 children here that I'm circling who we followed in a representative population-based cohort that were living throughout New York State. And we categorized these 700 children right here based on whether or not they had an anxiety disorder when they were adolescents, either no or yes, and whether or not they had a problem either with anxiety or with depression when they were adults. And there are three main findings to take away from this study that tell you everything you need to know about the relationship between anxiety in childhood and emotional problems in adulthood. The first thing is that anxiety is incredibly common in childhood, and this is abnormal anxiety, anxiety that's impairing. So as you can see in this study, out of the 679 kids, 253 had an anxiety problem. On the other hand, number two, most of these kids will be fine when they're adults, and this is very different from what we see in depression. So we see over here 191 of these kids had anxiety when they were children, but were fine when they were adults. It's only the 62 of the 253 who had anxiety both when they were kids and when they were adults. Point number three, when we look at the adults who had problems, there are 98 here, you can see that most of the adults who had a problem, 62 of the 98, had their problems start when they were children. So what this tells us is if you have an emotional problem as an adult, more likely than not, the problem started when you were a child. However, if you have a problem when you're a child, more likely than not, you are going to be fine. All right? And it is this type of relationship that makes us as scientists very interested in understanding the relationship between problems in children and problems in adults, particularly in their parents. This also relates to the way we think about novel treatments. So, for example, this group right here, these 191 kids, we can think of them as being resilient in some way. And what we know about resilience in neuroscience is giving us new ideas about treatments. So the big question that we want to answer is what distinguishes children who have these transient problems from children with persistent problems, something that we're only beginning to understand. So I mentioned that we're interested in this relationship between anxiety in children and adults from these longitudinal studies. We're also interested in it from family studies. And what we find is problems in anxiety run in families. So we see that in studies of parents who have psychiatric problems, and we see both parents with anxiety and parents with depression often have children with anxiety. So this makes us further think that if we can understand more about anxiety in children, we might be able to impact on later problems with depression. But we also find even earlier, when we look at studies of temperament, we find that the roots of anxiety and depression might be detectable through something called a behavioral inhibited temperament that we can see in young children even in preschool ages. Now, behavioral inhibition is not like an anxiety disorder. We don't think of it as anything that's necessarily abnormal, but what this tells us is that the initial signs and the initial kind of roots of problems with anxiety and depression might be identifiable relatively early, and this generates a lot of questions for us in thinking about how can we tell minor variations in anxiety that we think are clinically significant in young children versus those minor variations that are just part of the typical normal variations we see in children all the time. And so what, again, distinguishes kids who are born into families where they might be at risk who do fine over time, or kids who are resilient, versus kids who have trouble when they're born into a family that might place them at risk. All right, so the second thing we're going to talk about is treatment, and I'm going to try to give you the bottom line just in the interest of time. I'm going to gloss over some details of some of the specific studies, but maybe in the question and answer period we might have time to talk about some of these specific studies. So the bottom line is, both for major depression, as you see here, and for anxiety disorders, as you see here, there have been two types of treatments that have been examined. One of them is the SSRI, or selective serotonin reuptake inhibitor medications, and the other one is forms of psychotherapy, and there are really two forms that have been tried with major depression, something we call CBT, or cognitive behavioral therapy, and you see I have a question mark here, and something else called interpersonal therapy, and again you see I have a question mark there. In anxiety disorders, cognitive behavioral therapy, or CBT, is the main kind of psychotherapy that has been tried. And the bottom line from this slide really consists of two main things to know. The first thing is that in general, anxiety disorders are easier to treat than major depression. So children tend to have better responses to treatment when they have an anxiety disorder than major depression. So this further relates to this idea that maybe if we were to treat anxiety, we might do better in terms of the long-term outcome, as opposed to if we waited until kids first showed signs of depression. But then second of all, the range of treatments that has been shown to work convincingly is also greater in anxiety. So there's convincing evidence that selective serotonin reuptake inhibitors work in anxiety. There's equally convincing evidence that cognitive behavioral therapy works in anxiety. And as a result, when all things are equal, we recommend that we start in anxious children with cognitive behavioral therapy. Now, that doesn't mean we always start with cognitive behavioral therapy, because for some children that's really not an option. It just means when it is an option and there aren't other contraindications, that's what we want to start with.
Dr. Pine, can I interrupt for 1 second with a question?
Sure.
And I apologize because I'm trying to follow what you're doing and also check on some of the questions that are coming through. But you had mentioned two things. You talked about SSRI medications. Can you comment at all about the use of anxiolytics or, some of the just straight anti-anxiety medications as far as where those fall into play?
Yeah, so when we think about anxiolytics, we think about them in two groups. We think about them as antidepressants, and we call them antidepressants, but most antidepressants actually work better for anxiety than they do for depression, both in adults and in kids. And the only medicines that have been definitively shown to work for anxiety are the SSRI medications, or the selective serotonin reuptake inhibitors. The second group we think about are medications in the group known as benzodiazepines. Mm-hmm. So those are things like Klonopin or Valium or Ativan. And there's some evidence that those work in children. The evidence is not as strong, and the side effects generally are more significant with this group of medications than the SSRIs. There are two main advantages to those medicines, the benzodiazepines, again, things like Ativan. One is they work right away, where the SSRIs take at least a week, but usually longer to work. And the second is, if you're really concerned that a child might have bipolar disorder, in general, the chances of making the child worse are higher with the SSRIs than they are with things like benzodiazepines. Now, there's a whole bunch of other medications that people call anxiolytics and that have been studied quite extensively in adults, but none of them have really been studied in children. All right? Did that answer it?
Yeah, you actually read my mind. There was one other question that just came in that was related to this, if we can just take a minute for that.
Yeah, sure.
And that was, you had made the comment that anxiety disorders are easier to treat than mood disorders in children. Can you expand on that a little bit?
Yeah, so it's easier to treat in two ways. One is, in general, when we conduct rigorous controlled treatment trials of anxiety disorders, the data are much stronger in terms of suggesting the amount of benefit that any given child will derive from a treatment. The benefits are extremely large in the anxiety disorders, much larger than they are over placebo or other non-specific interventions. So one issue is that the magnitude of the response is generally greater, but then the second issue is the diversity of treatments that are available. Pretty much all the SSRIs, all 5 of them, have been shown to work for pediatric anxiety, where probably only 1 or at most at 2 have been shown to work for depression. But then also the data on cognitive behavioral therapy, or CBT, for anxiety disorders are very, very strong, much stronger than they are for depression. So it's both the overall magnitude of how well the treatments work, but it's also the diversity of treatments that are available. All right?
Okay. Great. And I'll just remind our audience that you're welcome to go ahead and submit your questions, and we can get those lined up so that we can send them through once we're at our next break or when we get to the end of the presentation. Thank you. Sorry for interrupting.
No, not a problem at all. And feel free to interrupt me again. Now, this slide, which you can make available, kind of shows the bottom line and relates to the things that we were just talking about, that one antidepressant has been shown to work convincingly for depression. That's fluoxetine or Prozac, and it does have FDA approval. There's weak evidence for a second agent, sertraline or Zoloft, but the data are really not very strong. And citalopram, a third agent, which also has FDA approval, has some evidence. Again, the evidence are not overwhelming, but they were enough for the FDA to approve these medications. Really, the evidence for other agents is not very strong at all. So it's not a great picture. And that raises a lot of questions about, why are these data so negative? questions that are really not easy to answer for scientists right now. But the bottom line is that depression in children is not easy to treat. And that's very different from the anxiety disorder. So this is probably the most famous treatment study of depression. It's called the TAD study. I'm not going to walk the audience through it since basically everything that I've been saying has been supported by this study and other studies like it. So the main thing to say about the anxiety disorders, again, which relates to things that I've already been saying, are reflected in this study, again, a study that I'm not going to walk you through, called the CAM study. And this is a study of non-OCD anxiety disorders and non-PTSD. And then a number of other studies on pediatric OCD. And the bottom line is, you heard me talking about major depression where I said maybe two antidepressants work for depression, but it's really only one. 5 antidepressants have been shown to work for pediatric OCD, and CBT, or cognitive behavioral therapy, also has been shown to work for pediatric OCD, and Prozac, Luvox, and Zoloft all have FDA approval. This is the most important study in OCD, but the bottom line is that the response rates in anxiety are much higher than they are in depression. The relapse rate is much higher in depression than it is in anxiety. So again, the idea is perhaps if we were to be more successful in the treatment of early pediatric anxiety, it might be a lot easier to address the problem of depression. The last thing to say about the SSRIs and the antidepressants is that there's been a fair amount of controversy about the association between the SSRIs and thoughts about suicide. This is an issue that has been discussed extensively, and it's based on these data from the FDA. And I was one of the panelists that were on the 2 panels that looked at these data that led to the black box vote about the SSRIs. And so a black box is the most extreme warning that the FDA can put on a medication without banning the medication or making the medication not available. And I can tell you on both committees, I voted against the black box. And I do think that was the right vote. If I had to vote again, I would vote against the black box again. But it was a difficult decision, and it was a difficult decision because of this slide. And this slide shows you the strength of the association between thoughts about suicide and the use of an SSRI. So you see that I'm circling this data point right here. Anything that falls to the right of this line, anything that falls to the right of this line means that an antidepressant is worse in terms of thoughts about suicide. Anything that falls to the left of that line means that the antidepressant is better. So you can see the data in children fall on the right, the data in adults fall on the left. So there is this association between thoughts about suicide and the use of SSRIs. And that was why many people voted for the black box. But the association is relatively weak. And in my estimation, the harm from a black box I viewed to be potentially greater in that I thought it was going to scare people away from using antidepressants. That said, this association with thoughts about suicide are real. And I can understand why people did vote for the black box. So here's kind of the bottom line about treatment. Number one, SSRIs are very effective in the treatment of pediatric anxiety. They're the best pharmacological treatment option we have by far. Benzodiazepines are reasonable, particularly when there are concerns about bipolar disorder, but in the absence of such concerns, SSRIs should be the first medication choice. The story is different in depression. Only fluoxetine has clearly been shown to be effective, and even there it's not as effective as it is for anxiety. and the increased risk of suicidality with SSRIs is real, but the magnitude of the effect is small. The other issue to consider here is what we said about CBT. The data are very clear that CBT are substantially effective in the anxiety disorders. The data are much more mixed for major depression. So, in the interest of time, I think I'm only going to take 5 minutes to talk about neuroscience and how might neuroscience help us. This is how I spend most of my time at the NIH, trying to understand how the brain works in pediatric anxiety in particular. This research has really only just begun. It has certain advantages, like what it tells us about how the brain works and what it tells us about ultimate causes. I think it's unlikely in my lifetime, and you can't see me, but I'm a very young-looking guy, but it's unlikely in my lifetime that we are going to have biological tests. We are not going to do brain imaging scans for diagnosis, I don't think. On the other hand, maybe 50 years from now we might. More importantly, we are starting to get ideas about new treatment. And what we're learning from brain imaging is more likely to impact on new treatment in the near future than it is to impact on diagnosis. So there are kind of two sets of things that I'm doing. And again, I'm gonna go through some slides fairly quickly so that we can get to the questions and the answers. But the first thing that I'm studying, and again, don't even try to read this, I'm looking at the relationship between attention, and you can see here, this shows how attention works when we're presented with danger. And so we know that people who are anxious are more likely to have their attention captured by a threat stimulus such as this snake. And my group over the last 10 years has defined the underlying brain architecture that produces this attentional perturbation in anxious children. And we are in the process of designing and implementing video games that children can use to train their attention. And we are just starting to show that these kind of video games might be helpful in children with anxiety disorders. Now, pay a lot of attention to how I said that. I said we're just starting to show that these video games might be helpful. You actually can go out on the web and you can buy these video games right now, and I would not recommend that anybody do this. I would say that this is a promising new lead that maybe in 5 years might actually impact on clinical practice, but I don't think this isn't the kind of thing that parents should be using yet. That said, if you live near the NIH, we are conducting studies right now using these video games, and I do think that there's a great deal of promise. And again, it comes out of the research that defines this relationship between perturbed attention and brain function in anxious children. So that's one thing that we're working on, and again, I'm going to skip through these slides. The second thing we're working on is we're studying how children learn about fear, and we know a lot about the underlying molecular architecture that's engaged when children learn about fear, and we're developing really new kinds of treatments that don't use video games, but use kind of novel teaching methods, some with medication, some without, to try to help children learn about signals of safety. So I wish I had time to go over the neuroscience. I'm thinking that parents are probably more interested in about what they can do for their children today, and none of the neuroscience really impacts on that today or even in the next year. So maybe what I'll do is I'll summarize the main things to take away, and then I'll open up for questions for the next 25 minutes that we have. So I talked a little bit about the nature of anxiety and the nature of depression. I talked about the differences between normal and abnormal anxiety and depression, and I talked about the varieties of anxiety and depression that we see. Most importantly, I talked about what happens to anxious children over time and how that's different from what happens to depressed children. That anxious children definitely do well, but the small group of anxious children who don't do well will grow up to account for the majority of chronic problems in adults. And that's really why we need to think about how better to serve children, understanding this relationship between familial aggregation, but also understanding what are the different risks and benefits of the current treatments that we have so that we can use neuroscience to go beyond these current treatments to come up with better, both safer and more effective treatments. So with that, maybe I'll open this up. Again, if you live in all the studies that we do, you kind of have to live near Washington. There's the line that you can call for patients. And then I put my email and my phone number on. I do not discuss specific clinical issues by email, but I'm free on the phone. Usually mornings are best, sometime between 8 and 9 a.m. if you want to call me. That's my direct line. So with that, I'll thank everybody for their attention, and maybe in the remaining minutes, I'll hear some questions.
Great, and thank you. We do have a lot of questions coming in, and I wanted to say you're very brave by giving out your phone number and email address because
I haven't lived through credit yet.
Well, we're very appreciative of that. We have a really great array of questions coming in, so I'm going to do my best to sort of organize them. I'd like to go back for a minute and talk about something you said fairly early on about anxiety being incredibly normal in childhood and the longitudinal studies that were done that backed up that assertion. And I know for those of us who are parents who have lived with kids with anxiety, I'm not sure that we would use the word normal. But can you talk about how far back those longitudinal studies went, what kind of a window you're looking at, and how, if there's any change over time, that we're seeing an increase in, quote, normal anxiety in kids, or has this been
so there are really three things to say about that. The first thing to say is a number of people have done a number of studies, and they really all generally show the same thing. Our studies have started as early as about 3 and have gone as far as into the 40s. And the story is relatively the same in all the studies. So that's the first thing to say. The second thing to say is that there are not a lot of obvious predictors about, which child you see is ultimately going to fare well and which child is going to have more problems. And parents and doctors always want to know those kinds of things. And we've looked, and there are not any obvious predictors. There are some predictors in some of the brain function measures we collect, but even there, they're not ready to be used routinely clinically. The third thing to say is that parents frequently ask, is there anything that I can do if I have a child who has anxiety and I want to encourage them to overcome their problems. And one thing that we've learned that really does ring true is when we've looked at young children and we've looked at differences in terms of how their parents respond to their child's anxiety, we do see something quite striking that I think is important for parents to know. And that is, particularly in our studies among very young children, we found that parents who tended to encourage the children to face their fears, generally the kids did better over time. So what do I mean by that? So for example, there was a relatively large group of kids who really did not want to do things out of the home, didn't want to go to daycare, didn't want to go on sleepovers, didn't want to go on parties, and parents took very different responses to those kids. And we can understand that. I work a lot with anxious kids, and it's incredibly painful when a kid is in an anxiety-provoking situation. And your first instinct is to do whatever you can to minimize anxiety. Some parents you know, they push their kids, and they say, I know it's hard, but you know, you need to face your fears, and you need to go out there. When we follow kids over time, the parents that did push their kids, those kids did tend to overcome their anxiety. Now, you know, that doesn't mean that you want to push your kid to the point where it's unreasonable. And one of the places where I think pediatricians and other clinicians can be most helpful is helping parents decide how much pushing is too much. But that's probably the most important take-home message, that, you know, while your first instinct might be to protect your child from everything that makes him or her afraid, some degree of anxiety is important, and particularly for kids who are relatively anxious, pushing them might be even more important than pushing the kid who's not very anxious.
Okay, great. Thank you. We have a couple of questions that are coming in regards to medications. Are you comfortable with fielding those?
Sure.
Okay. Two people were asking about the success rate with Seroquel. Do you want to comment as far as the role that would take?
Sure. Seroquel is in a group of medications called the atypical antipsychotics. And the atypical antipsychotics are a pretty controversial group of medications. And they're controversial for a few reasons. And this question relates to one of them. The medications are relatively easy to use, and they tend to help diverse kinds of problems that kids have. So there has been a tendency among physicians to use them relatively frequently. And you know, there's variation among physicians in terms of how comfortable they are using those medications. And I'm one of those kinds of physicians who's not particularly comfortable using them, particularly related to the question that was posed. And that concerns the use of medications like Seroquel or atypical antidepressants for anxiety. In general, there are other options that work every bit as well, if not better, and that have been studied more extensively. So one would only want to think about using a medication like Seroquel in a child with anxiety if other things are either off the table or have been tried. The second thing to say is the tricky thing about this group of medications, they tend to be relatively easy to use in the short run, meaning that the side effects that you get with them acutely can often be less than what you see with the SSRIs, but there are a lot of concerns about the long-term effects of the atypical antipsychotics, in particular the association with weight gain and the risk for diabetes, but also some of the long-term neurological effects of the atypical antipsychotics are greater than what you see in the selective serotonin reuptake inhibitors, or SSRIs. You know, the trickiest thing is if there's a question about a bipolar diagnosis. I think in that area, if a child has been psychotic or if a child has a history of bipolar disorder, it's a more reasonable thing to think about a medication like Seroquel. In a child where there's no such question, then it's one of the things that I would only consider fairly far down the list.
All right, thank you. We have a question now about anxiety that's induced by trauma. The example that was given was children that are in the Louisiana area who've been through a great deal of trauma due to some of the storms, and a lot of them are experiencing anxiety and depression. Can you talk about whether there are any differences as far as treatment for children who are experiencing these illnesses due to post-traumatic stress disorder as opposed to more garden variety?
Sure. That's another excellent question. So probably the most important thing to say about children who have anxiety related to trauma is that there's really a wealth of research about the different kinds of psychotherapies that have been shown to work. So in particular at Louisiana, there's a psychiatrist named Mike Sheringa at LSU who has done really just wonderful work using different kinds of psychotherapy that are quite effective in kids who have undergone trauma. And really the expert who has worked with Dr. Sheringa is somebody named Judith Cohen, Cohen, and she has written a number of books, both for practitioners and for parents, that talks about some of the different techniques that can be incredibly helpful in psychotherapy for anxiety. The last thing to say is that in many ways, anxiety about trauma is really horrendous, and it's one of the worst things that you can imagine. There are a couple of things that make it very well treated, and probably the biggest one is when you're trying to develop a psychotherapy, if there's a particular thing on which you can focus and you can help the child to overcome, then psychotherapy tends to work quite well. So for children who develop anxiety after trauma, we think that that's why some of these psychotherapies are so helpful, and that's really the kind of thing that parents want to think about as the first line.
Sorry, I'm turning my mic on and off so that I don't pick up the background noise. Okay, we have another question here about the prognosis for kids who have psychosis involved, either because of severe depression or they have other comorbidities going on. Can you comment at all about what the recommended course of treatment would be in that area?
Yeah, well, so first let's talk a little bit about prognosis. The good news is that children are incredibly resilient, and even children with disorders that tend to be more chronic, like depression or psychosis, tend to do relatively well, often better than adults who have similar conditions. So that's the good news. The bad news is that the data are not nearly as encouraging as they are for anxiety. So I think most people would think that it's closer to 50% in terms of when we follow those children over time who do really well longitudinally. And in terms of treatment, probably the most important thing is that having access to a center where there is a lot of experience in terms of taking care of children with those kinds of problems, that's probably the most important thing that you can do. For some kinds of problems, problems like anxiety, as well as attention deficit hyperactivity disorder or ADHD, there's really a wide variety of experts that can provide very helpful treatment, including pediatricians. That tends not to be the case for children who have psychosis or who have severe depression. You really want to be in the hands of a group where they've had a fair amount of experience with those kind of problems.
Okay. We have a question now about different types of therapy. You made several references to using CBT and that being successful. Can you talk at all about the use of family therapy as a component of that or as an adjunct?
Oh, so that is another excellent question. So that's one of those things that's somewhat controversial, and it's controversial for the following reason. It's very clear that families have to be involved when young children have anxiety for the psychotherapy to succeed. And so even where the therapy focuses on the individual, the family must be involved. Where the controversy comes in is that there are certain kinds of family-based therapies that make incredibly extensive use of the families, that involve the families in virtually every aspect of the treatment. And the controversy comes in about whether that provides any added benefit or not, that the jury is still out if that is necessary or not. As long as the therapist is working very closely with the family and the family is involved in treatment, some clinicians think that that is sufficient, that you don't need to specifically go see a family therapist, for example. The last thing to say is that probably the most important determinant about whether psychotherapy works or not for anxiety, which is very similar to the thing I said about the long-term outcome, is whether or not the child can undergo exposure. And so the place where families are incredibly important is that most of the exposure that anxious children must undergo does not happen in the therapist's office. It happens back in the home. So that's where families are really most important, by working with a therapist and by figuring out this balance between what's enough exposure versus what's too much to be traumatic. And that's really where the family must be involved.
I think you make a very good point there, and that also it really depends on the child and how open they are to the whole concept of therapy, that you don't want to use, to an extreme or push to the point where they become resistant to any aspects that were already helpful.
Sorry,
go ahead.
One more thing about that. One of the questions that I get most frequently is about when should I use psychotherapy or when should I use medicine? And it really comes down to, can the child tolerate the therapy? That there are a lot of children who it's just too traumatic for them to undergo this kind of therapy. And when that's the case, it's absolutely the right thing to do to not try anymore and to try medication first.
And I think that's a very good point, which is sort of a lead into my next question, which is going to be, if I do this right, an amalgamation of several questions that have come in, which is really around the concept of which came first, the chicken or the egg, because many of our families are dealing with alphabet soup, so to speak, with a lot of different diagnoses. There's a lot of changing in the diagnoses over time, and you get to the point of wondering whether the anxiety or the depression is a symptom of a larger diagnosis or a situational aspect of their lives. So, for example, if you have a child who's dealing with Asperger's and is dealing with some social challenges to start with, is that feeding into and creating the anxiety or the depression, and should it be treated, or is this more of a symptom of the overlying disorder? Same with ADHD or oppositional defiant disorder.
So the main thing to say about those kinds of questions, complicated cases, is that most problems in children, particularly when they involve many different varieties of problems, anxiety, social problems, depression, anger outbursts, for those kinds of problems, it's almost never one thing that caused the problem. It's usually some very complex amalgamation of 10 or 15 or 20 different things. And typically, it is virtually impossible for any individual child, even when you think back on it, to kind of sort out where the chicken was and where the egg is. The most important thing to really think about is for each individual child to try to prioritize in your mind what problem is the most significant. What's the problem that I really want to focus on in most depth? Because the thing that happens in children who are having problems like that is you're forced to make compromises, and you cannot expect to handle every problem all at once. And the kids usually do better over time if you kind of chip away at the problems by, selecting the first problem that you think is most significant and then trying to do everything you can to take care of that one, and then trying to chip away at the second one and the third one. And where experts really come in is it's a fine balancing act, because what often happens is, you're taking care of one problem and then another problem gets worse. And so then do you stop taking care of the first problem and shift to the second one? Again, it's really a fine balancing act, but you've got to really try to remember, and I say this to the young doctors that I train, as well as to the parents that I work with. You got to really try to remember to try to only do one thing at a time, to only change one medication at a time, to only try one new kind of treatment at a time, because you can never figure out what's helping and what's hurting if you do two things at once.
Right, and I know that's sort of basic science 101, that you manipulate one variable at a time, but I know that for parents like myself and the other people here, that often it's very hard because there's such a long ramping up period before you know if something's working or not. But well, you're absolutely right.
It's hard for the doctor, too. I write it down and put it under my desk, and whenever I feel the urge to do two things, I remember, every time I've done it, I've regretted it, even though, I feel the urge every day.
Right. Our psychiatrist refers to it as watching paint dry. That's the process is so slow and boring, but it is what it has to be. I agree. We have another question about a behavioral issue, and that's in regards to violence, and particularly with younger kids where we know that they don't have the emotional maturity or the language or the experience to really convey what's going on inside of them. How do we address any relationship or lack of between violent behavior, aggression, and anxiety and depression? And do you have any recommendations as far as therapeutic or medication for treating that?
One of the things that's hopeful about violent behavior, particularly in very young children, is it's also incredibly amenable to properly done psychotherapies. And the book that I make every parent who I work with buy is a little book that I'm looking at right now. It's called Families, and it's by a guy named Gerald Patterson, Patterson. It's about 60 pages long, and it walks parents through what are the kinds of management strategies that often work best in violent children. So that's the first thing to say. Second thing to say is, safety is always the most important thing, and that's when, all plans end up getting thrown out the window. When a child's violent, you've got to do what you can do to protect that child and the family, and it's difficult for everybody, the child, the family, and the physician. The last thing to say is this is a place where, medications like the atypical antipsychotics like Seroquel, that's the place where I think those medications are a reasonable thing to think about. Because again, when you're really worried about violent behavior and aggression, and it's an acute issue where safety is a question, then you need to do something that's going to protect everybody. And I think that's the situation where those medications are justified if things like psychotherapy that's described in that book have failed. I guess I would like to reserve those medications for situations more like that, if I were to say one thing about them.
Okay, I'm going to ask you just one more time to repeat the name of the book. You said it's just called Families?
It's called Families,
and
it's by Gerald Patterson. It's a very old book. It's the book I used when I learned psychotherapy almost 30 years ago.
Okay,
so,
well,
written in the 70s. You can get it on Amazon. I have every parent who has any behavior problem in a child buy the book, and I read it with them, and we kind of go through these kinds of strategies.
Great. Well, we're always looking for new tools because...
Another really good book for anxiety is a book called Helping Your Anxious Child by Rapee. That's R-A-P-E-E. So that's a very similar book. Those are, as far as parents' resources, those are two of the best.
Okay, that's great because these are definitely different than the ones that we've been referring people to for quite some time. We're almost out of our time, so I would like to finish up with two last questions in regards to medications, if that's okay.
Sure.
One is regarding the use of Wellbutrin, which is not an SSRI, and I know is sometimes an option for families who are dealing with potential bipolar or other mood disorders. Do you want to comment at all on your experiences with that?
Yeah, it's another one of those medications that people like because it tends not to make things worse, and I do think that's the case. It rarely makes things worse. The only thing that it's really been convincingly shown to help, and even there the data are not that convincing, are attention problems in children. It does not tend to help anxiety. It does not tend to help mood problems, and it does not tend to help aggression more than placebo. That said, it tends not to make things worse.
Okay, but does it make things better?
Next one.
Okay, the next one is
it can make attention problems better. That's the only thing that it's that I've found it convincingly to help.
Okay. And then our last question is regarding the long-term use of SSRIs, as far as whether that does anything to disrupt or restore the natural production of serotonin.
Yeah, boy, that's one of those, I have to say, that's one of those questions for which nobody has an answer. It is one of those questions that we've been spending a lot of time at the NIH trying to understand. I will tell you this, there's no convincing evidence that it's harmful, and I would say that the evidence that stress harms the brain is every bit as strong, if not stronger, than the evidence that things like SSRIs harm the brain. So I think for that reason, it's completely reasonable to use SSRIs on the one hand. On the other hand, there is a lot of research about the role of serotonin in brain growth, and I think that the jury is still not out about whether or not there are long-term effects of the SSRIs. And that's why we're spending a lot of time studying it. And I routinely, particularly for a child who has done well, I routinely work with my parents to try children off of SSRIs. Now I'll tell you, it's really tricky because I've had a fair number of parents who are ready to kill me because we've had a child who's done really, really well. We take them off the SSRI, and you know things go really poorly. So it's one of the most important questions about the relative advantages and disadvantages of long-term SSRI use. And what I would say is that we just don't know, that we can be more confident in anxiety relative to depression, that it would be good to have a trial off of the medication. And then last of all, it really comes down to the parents and the child sitting with the doctor and kind of weighing a bunch of unknowns, unknown risks, unknown advantages, and kind of picking where do you want to take a chance. Do you want to take a chance that a child might relapse on the one hand, or do you want to take a chance that we're not going to find out anything concerning about long-term deleterious effects?
I think you've summed up very well what we as parents struggle with, is that some of these are choices that we really don't want to have to be making, yet we do have to make those choices, and we're certainly very, very grateful for the work that you and your colleagues are doing to further research so that in the years to come that we will have more information so that we can make informed decisions. And we're certainly very grateful for you spending the time today to share your experience and your knowledge with us, because I can see from the comments that are coming in that this has certainly been very helpful for a lot of the attendees here. So we're at our hour. It went very quickly, and I again thank you from the bottom of our hearts for the time that you spent with us, and we will have the recording available on our website hopefully within the next day or two, and continue to check back because we'll have 4 more of these webinars coming up over the next 2.5 months. And thank you very much, Dr. Pine. This was very, very informative and very helpful for us.
Okay, really great for me too.
All right, thank you so much.